Hello, welcome to the second emergency medicine playlist video. Today we're going to be talking about primary and secondary surveys. My name is Dr. Taylor Anderson, professor of medicine, emergency medicine, and critical care medicine. Initially, we're going to start talking about history taking. So it is important that you familiarize yourself with the ABCDEs when examining a trauma patient. If the patient is conscious and aware, learn to use the PQRST or OPQRST mnemonic for extensive assessment of the patient. Another form of initial assessment is your ABCs. However, for patients who are hemorrhaging or severely bleeding, you may change it to CABs. So note that sample, so symptoms, allergies, medications, past medical history, last intake, and events, is only used for secondary surveys and are not for initial trauma surveys. So for airway, we want to check for any foreign bodies, peritonsillar hypertrophy, bleeding or vomits, and saliva within the oropharyngeal space. So you may refer to the anatomy shown and represented on the right side. For airway, you'd also like to check for patency, so that means the mouth is opened and unobstructed. You want to check for any visible deformities that can occlude the airway. You also want to check for any maxillofacial fractures as well. Okay, you may use chin lift or jaw thrust maneuvers to calibrate airway alignment. Airways such as oropharyngeal airways, nasopharyngeal airways, supraglottic airways like laryngeal mask airways, and definitive airways like intubation with a secured endotracheal tube. In severe situations where other airway adjuncts are not permeable or available, a needle or surgical cricothyrotomy will be established. You may predict intubation outcomes by using the Lemon criteria. So look means check for any micrognathia. This is when the lower jaw is smaller than normal, or any maxillofacial trauma, or any other external signs. Another one would be to evaluate the 3-3-2 ruling. So it means they can either accommodate 3 fingers between their midline front teeth with their mouth fully opened. Next one is that they should be able to accommodate 3 fingers between their chin and hyoid bone. And finally, they should be able to accommodate 2 fingers between their thyroid cartilage to the floor of their mouths. Next one is Mallampati scoring. So you want to assess the airway using this criteria. There are 4 divided classes. So you have the first class, which is full uvular visualization. The second class is the tongue occludes distal portion of the uvula. The third class is the entire uvula is occluded except for the base and proximal portion. The fourth class is when the uvula is unable to be visualized. So next part is going to be obstruction. Are there any foreign bodies or fluid seen? Next one would be neck mobility. So patients who either has a C collar on, has limited movement either from a C-spine or a injury to their spine itself. Short necks, obesity can hinder the placement of an endotracheal tube. So breathing itself, you want to check for complete examination of the diaphragm and the chest wall, as well as the other surrounding vasculatures like the intercostal muscles and the ribs. You want to look for any rib fractures or paradoxical chest movement. So this is the indication for flail chest. Atelectasis, which basically means a collapsed lung or lobe, may occur from the lack of proper breathing. You want to palpate the chest wall for tenderness. Crepitus, basically meaning popping or clicking or cracking sound in the joints, and other visible deformities. Next one is you would like to bilaterally percuss the chest for hyperresonance and dullness. If a flail chest is present, usually this is indicative of pneumothoraces. So a needle decompression or chest tube placement is needed to inflate your lungs or drain off the fluid from the thoracic cavity. Please do refer to your chest x-ray. Note that some patients may need supplemental oxygenation, either from airway adjuncts or pain medications for chest wall injuries. Be sure to check for pulsatile strength from both central and peripheral pulses. You want to inspect the skin color, the warmth, and deformities that includes blood flow. You may order a fast exam. So this is a trauma exam using an ultrasound, a chest x-ray or CT examination for further assessments of the patient's cardiological status. You want to start the patient in either fluid replacement for increasing perfusion pressure. This is mostly used in patients with hypovolemia. Next is the appropriate use of the mass transfusions protocol and the vasopressors like epinephrine, norepinephrine, dobutamine, or dopamine. You may use the Glasgow Coma Scale for assessing neurological status, a urine output to assess for kidney function. You may check the patient's blood pressure for assessing perfusion rates, and cardiac contractility for heart rates. Usually, we'd like to start the patient on a 12-lead electrocardiogram. An electrocardiogram basically is a way in how you can see the function of the heart. What you want to do is you want to check for any arrhythmias, so that means supraventricular tachycardia, ventricular fibrillation, ventricular tachycardia, atrial fibrillation, atrial tachycardia, and premature ventricular tachycardia. You want to check for any cardiac strain and palpate apical pulses. You may perform an electrocardiogram if suspected of any underlying pathology. You may auscultate the patient's heart for any murmurs, bruits, or gallops. Just so you know, any findings in the electrocardiogram which shows electrical alternates, hypotension, distension of the jugular veins, and muffled diminished heart sounds upon auscultation is the classic presentation for Beck's triad. Now, this Beck's triad is primarily used for assessing cardiac tamponade, and usually a pericardiocentesis may be required to drain off the fluid. Next part is disability. So note that imaging like computed tomographies or magnetic resonance imageries are only done if the patient is hemodynamically stable, or if the patient's condition can tolerate the length of study without any clinical intervention. Exposure and environment. So ideally, you'd like to expose the patient from head to toe for identification of occult injuries. You may also perform a log roll if needed. A log roll basically means you're going to turn the patient to the side to see for any injuries in the back. For example, gunshot wounds, you want to check for any exit wounds. Also, be sure to maintain the patient's core temperature to 37.6 degrees Celsius or 98.6 degrees Fahrenheit. Note that this value may vary with different individuals. Now moving on to quick assessments. As mentioned earlier, the usage of the Glasgow Coma Scale is to identify appropriate neurological function. You may use the AVPU scale for pain and responsiveness. You may also use Pearl as a way to identify neurological function, as a way to check for pupil quality, shape, and reactivity to light. So moving on to blood pressures. Normal blood pressure is 120/80. Patients with low blood pressure are classified as patients who are hypotensive. Patients who have high blood pressure are patients who are classified as hypertensive. Today we'll be talking about the different types of hypertension. However, I simplified it to prehypertension and hypertension. So for pre-hypertension, you'd usually see the systolic value of 120 to 139 millimeters of mercury. For the diastolic value, you'd see a lower than 80 millimeters of mercury. Patients with hypertension, you'd see a systolic blood pressure of 140 millimeters of mercury or higher, and a diastolic value of greater than 90 millimeters of mercury. So now moving on to oxygen saturation. The normal oxygen saturation is 95% to 100. So patients who have a value of lesser than 95% is hypoxemic. Patients who have the value of greater than 100 has hyperoxemia, which is basically an excessive oxygen in the bloodstream. Normal heart rate is 60 to 100 BPM or beats per minute. Bradycardia is classified as a heart rate of lesser than 60 beats per minute, And tachycardia is classified as a heart rate of greater than 100 beats per minute. Other miscellaneous test is the capillary refill time. So normal values are lesser than 2 or lesser than 3, so it means 2. Basically, how you'd like to check for the capillary refill time is to elevate a hand, or either hand, left or right, above the mediastinum, apply pressure for 10 seconds, either on the thumbs, the index finger, etc., and wait until it turns pale. Then after 10 seconds, you'd want to release it and count how long it will take for the index finger to return back to its normal color. Moving on to fast blood glucose test or finger stick. The normal values are 70 to 100 milligrams deciliters. Okay, so this is used to classify a patient who is hypoglycemic or hyperglycemic. The next value is the end-tidal carbon dioxide. So the values are usually normally within the ranges of 35 to 45 millimeters of mercury. Just note that this value itself is normally seen in waveform capnography. Thank you very much. If you do love these types of videos, let me know and I'll keep making them.